Okay. Hi, good night, everyone. Welcome to our session on grand rounds in emergency department. And this is in collaboration with our 5 main campuses across the Caribbean. And we are fortunate enough to have St. Augustine hosting it this round. And we'd like to thank our predecessors, Bahamas starting us off, and then followed last month by Barbados. So welcome, everyone. Thanks for taking the time to join us on this in Trinidad very rainy night where we are on orange alert. So let's be safe out there. And for today's grand rounds, we are indeed fortunate to have one with us, a person by the name of Dr. Michael Euwema, who is basically trying to become our ASEP representative for Trinidad and possibly wider Caribbean. So what is or who is Dr. Michael Euwema? So he is an emergency physician attached to Orange Park in Jacksonville, Florida. He's been practicing emergency medicine for 27 years, 19 of them as an emergency physician. Of note, you might see this in the slides, so be particular about it, or be a reminder that 11 years experience in the US Navy as both a fighter surgeon and also an emergency doctor. He has served on several administrative roles in his department, and he has a core or knack or teaching or inclination towards resuscitative transesophageal echo. So that's something to look forward to. Michael is happily married to his wife, Danielle, and you may see a picture of her. I wouldn't give away that. And also be mindful of, if you happen to see in the background, any dogs lurking in the background. There's a white American pit bull by the name of Jenna, and another dog that is in the back, name of Oscar. So just some housekeeping rules before we hand over to Dr. Michael. Just make sure mute your microphone, and you can keep your video on if you want, and we'll save the questions at the end. Okay, so I guess we have YouTube people, our moderators watching YouTube, and also the chat, the Zoom chat for any questions. During the course of the, after Dr. Michael presents his talk, Dr. Paul will affiliated and be associated with taking the questions and leading the discussions. Okay, so once again, thank you very much for joining us. And now we hand you over to our esteemed colleague, Dr. Michael. Thank you, Dr. Michael.
Thank you very much for the introduction. My voice coming across okay?
Perfect, yeah.
Okay, excellent. Yeah, Oscar probably won't get up. It's a little too much effort for him, so, but maybe he'll poke his head out. Well, thank you very much for the invitation. I suddenly forced myself into your view a few months ago after trying unsuccessfully during COVID to reach out to people that I didn't know. But I've been visiting Trinidad for many years, since I think 2013, fell in love with the country and the Caribbean in general, but I have many friends in Trinidad, so I returned there. And out of it, I was a practicing emergency physician then. I got very interested in how emergency medicine was practiced, but had no practical way to find out. So my relationship with you hopefully will grow, and hopefully the colleagues that I have in our program here will also grace the screen someday, that we can all grow that fraternity that is emergency medicine. It's a unique club to be in. I'm honored to have been doing it for so long, and I know all of you, the moment you start seeing patients in the emergency department, you fall in love with the specialty, because we have to know everything and we have to do everything, and we're the last ditch effort for someone to get an answer. So it's a humbling position to be in, but it's quite exciting too. So I'm grateful that I can commune with others around the world who have that same passion for that kind of medicine. Just figure it out. So when Dr. Paul and I started talking about topics, I happen to like toxicology, but as a disclaimer, I'm an emergency physician. I did a residency program in the United States. I'll give a few details. And I am not a toxicologist, but we were fortunate to have one in my residency program. And you'll see a quote from him later that I hope will spread throughout the Caribbean, and you'll say it to all your colleagues. But we'll get to that a little bit later. But I am a practicing emergency physician. Toxicology is bread and butter for us. We are the people who are supposed to recognize it. So I thought I'd take a 1,000-foot view and then sort of couch it in some examples of real cases that I've seen very recently and also throughout the years. And I'm pretty sure that because you're all involved in emergency medicine, many of you will find these cases very typical and very easy. Others might find them a little challenging, but it's the intellectual exercise that we need to do every time we see a patient like this. There will be a lot of facts in these slides. You don't need to memorize what I'm saying. It's all available through free and open access in medicine. I'll direct you to different resources you probably already know about, but this is just sort of to frame your mindset for when you're approaching a patient like this with some real examples. And hopefully at the end, we go out and we practice this way, and you pick up a few things maybe that you didn't know. So before we start, Dr. Paul encouraged me to let you know who I am because you may see me again. And I hope that this is more than just a guest lecture. I hope this is an ongoing relationship, a brother and sisterhood. And I know that sounds kind of sentimental and sappy, but that's the kind of guy I am. The more you hear me talk, you'll realize that. But it is, it's an honor to know other people who have that same passion around the world, and we speak the same language. So I hope that this relationship flourishes and we can learn from each other, because you've had to solve problems that I haven't had to face, and maybe vice versa. So I want to take just a moment to also mention Dr. Ed, who is on the call. His face just popped up. He's one of our best residents. I can say that because the others aren't here yet. But Ed abandoned internal medicine for emergency medicine because he got so enamored. But thanks for coming, Ed. So hopefully we'll have more of our residents joining too. Enough of a preamble. I should probably get to the meat of the meal. Just a little bit more about who I am, to embellish a little bit. Instead of words, I like pictures. So I went to a liberal arts school called Kelvin College in Grand Rapids, Michigan, where I'm from. I'm from the United States, obviously. There's the Dutch flag there on the right, and then the Michigan flag in between. My parents are immigrants from the Netherlands. They survived World War II and came to the United States and were refugees. So I'm a son of an immigrant. The whole world is full of immigrants. So I'm honored to have that distinction as well. I went on to Wayne State University in Detroit, Michigan, which was quite a training ground. We called it the Gun and Knife Club. We'd often hear gunshot wounds. We'd often see them, but we'd hear gunshots as we walked out of the lecture hall because Detroit Receiving was right across the way. But great place to train. And then I became certified in the American Board of Emergency Medicine after I graduated. And you'll notice that I went through a lot of different companies, and I got tired of changing the logos on my scrubs. So I was most proud of that, being an emergency physician, and one with formal training like you all have as well. What did I do for fun? Well, I did my internship in family medicine, and then I went out. I was in the Navy to help pay for medical school because I didn't have the means to do it. So I joined the Navy and I got to fly around in these things. They're SH-60 helicopters. There was a squadron in Japan. I spent 4 years there. I dated and then married my wife there. She was a Navy nurse. So the Navy was quite good to me. And I got, these are flight surgery wings, and that was my squadron. So my life in pictures. So then I had to get serious at some point. I thought I was going to leave the Navy, but I went to do the match. And at that time, it was just the time the internet was getting faster than 56 and dial-up. I would have had to go to my campus to apply for the match. I was in Japan, that was in Detroit, a bit of a problem. So I applied for the Navy residency, and this is the Naval Medical Center in Portsmouth, Virginia. Big facility, great training, but not a lot of sick people because we had active duty people with great access to care and pretty young and healthy. But we certainly got a lot of subspecialty care, and we went out in town. It was good training. And that was in Virginia, and that's what I used to look like. And this is a cautionary tale. Look at this young man here with a lot of potential, and now look at me. Don't let emergency medicine do this to you. You will turn gray. That can't be stopped, but the rest of the physical changes you have control over. So don't let it consume you. Let it energize you, and don't forget about yourself and your wife and your kids and your family and whatever your passion is outside of it. Always balance those things. So after finishing my residency, I went to Jacksonville, Florida, and then I also was attached to a Marine battalion. So I ended up in Iraq in 2005. It was an honor to serve. I was fortunate in the military. I didn't have to wrestle with the ethical decision of, do I shoot or not? That was not my role. I was there to treat everyone. And that's another thing about emergency medicine. You don't care who shows up. They're all patients. You treat them all equally. And you don't have to worry about that because you got so many patients. It's not like running your own business. And I assume it's the same way where you are. So I spent 9 months there. I listened to my third daughter being born over the phone. And when I came home, my wife said, okay, it's time to get out of the Navy. So I liked my wife more than I liked the Navy. I got out. So I settled here in Jacksonville, Florida, and I literally walked into this hospital. It was called Orange Park Medical Center at the time. It's the one on the lower right. That's the Florida flag. And a few miles away from the Navy hospital where I was stationed. And I said, I'd like to do a little moonlighting. They said, well, how about we hire you? And the rest is history. I since 2006, I've been there and I haven't left. Great place to practice. It's a small hospital that's now grown into a trauma center and a tertiary referral center. About 4 years ago now, we started an emergency medicine residency program, and it's been flourishing. Our first set of graduates are all working, being successful. We have 36 residents in total each year, 12 per class, and it's been terrific. I thought that my career was going to be an emergency physician and treating patients, but it is plus some. So if you have the opportunity to be an educator, to teach, it'll keep you fresh, it'll keep you excited, and it'll keep you loving what you do. So I highly encourage it to pass along what you know. Why the Trinidad connection? I alluded to it already that we've been visiting. That's my wife and family. You were right. There's some pictures, and my wife is in the lower right as well. The child she's holding is not one of my children, but she was just showing me how beautiful the children in Trinidad are. It's still stunning and amazing what beautiful people there are here. We fell in love. We have friends here that we visit frequently. They visit us. And most of the work that I've done has been in Tunapuna and also in the St. Augustine area, ironically. I didn't know that the school was that close, but then also in Laventille, if you recognize that painting. There's a special program called Hearts and Minds that if you'd like to know more about, I'd be happy to tell you offline. So I was talking about having difficulty reaching the right person because I didn't know your infrastructure. But when COVID lifted, I was able to come and I had a connection. So I went to this hospital that you might recognize in Port of Spain. And I met the emergency room director there, and he gave me the number for Dr. Paul, and the rest is hopefully going to be good history. I knew about the University of West Indies, but I didn't realize how robust of a program he had. And that's where we are today. We're hoping that our residencies at least can have a kinship or be like siblings to each other so we can learn and possibly visit each other to see how emergency medicine is practiced. But that relationship is just starting, and I'm excited to see what happens next. So that's who I am. That's where I came from, and that's where I hope things will go. And I very much look forward to meeting all of you and being in a mutually beneficial relationship. Hopefully, if I can be the ambassador through ACEP, I think that will happen. I've got some hoops to go through that will at least give me some more resources that I can bring as well. And in the end, I'll bring up a program that ACEP is exploring to try to improve their international reach. And ACEP, if you don't know, what you probably do, is the American College of Emergency Physicians. So that's enough about me. Now let's talk about what we came here for, which is toxicology. Just some statistics. We have a pretty robust poison control system in the country. It's unified by one phone number. It's kind of a palindrome if you take off the 1-800 part, 222-1222. And I have my residents memorize this number and repeat it to me frequently. Because if you're anywhere in the country, you can call this and it will divert you to a regional center. These resources are invaluable. And one of the best things you can do as an emergency physician is realize you're supposed to know everything, but you don't. And if you recognize that you don't, you seek out that information wherever you can, whenever you can. So our residents will call the Poison Control Center frequently, even if they know the answer, because there's usually one fact that they can add to their library in their head that will benefit another patient. So always be reading, always be learning, and never think that you have it all down. These are just some statistics that you can generate from a new program on the website. It'll give you relatively recent data, but you can see there's 2 million human exposures that they get calls about. But they get calls about people who are stung by stingrays, people who are bit by alligators. True story. I was one of those phone calls. I live in Florida. Alligators probably number more than people down here. We like to eat them though, and they like to eat us. So it's a very contentious relationship. But you can get all sorts of information from there. And it's not all about depression and suicide. It's about accidental. And only the Poison Control Center filters a significant amount of those, 80% almost. Only 21% of those end up in emergency departments needing help. So they're a great service. And they go across all 50 states plus all the territories of the United States. If you dig down just a little bit to see what kind of ingestants are the most frequent, analgesics top it, which probably is no surprise because they might have the most adverse effects, but household items, cosmetics, and so on. 42% of those cases were children who just do it innocently and hopefully never on purpose. But as you know, as we progress, we realize that the depression and things that plague adults is now reaching children as well, maybe because of COVID. I think we have to keep our eyes open more. 88% of them were single substance exposures, but that's that 10% that will get you, and understanding there's always something you don't know. If we just look at Florida in 2020, there were over 100,000 human exposure cases. That's about the number of patients that we see in our 3 emergency departments for our facility, if every one of those patients was an ingestion. So just in the state of Florida, there's an average, a case of every 280 seconds, there's an adverse ingestion incidental. So, and this is our phone number again. This is a number that you might be able to use if all other resources are unavailable. You'd have to pay a toll. I don't know if they're licensed outside the United States, but if you ever have a last-ditch effort, might as well give it a try. But what resources do you have? When I talked to your professors, ToxBase came up, which is a UK-based resource. UpToDate is available all over the world. StatPearls is all over the world. But you also seem to have your own regional poison control centers, so use them. A lot of times the phone calls you make determine their funding, because if they're getting lots of phone calls, they can justify a bigger budget. So you calling them is not a burden, it's a way to feed this valuable resource. Now, I don't know about the Sangre General Hospital. When I looked at it, I saw some pictures. It looks like to be a hospital on the east side of the island. So please don't, if these are not the most valuable resources, I apologize, but I just tried to make a connection just to the island that I visited. So when we're talking about toxic ingestions, what are the management principles? It always starts with what you do with every patient that shows up. You stabilize them. You may never know what their ingestion is, but if you can handle an airway and you can keep the blood flowing and you can get them to that next stage, the ICU or whatever it takes, then you've done your job as an emergency physician. Our job, I think Dr. Rosen, who wrote the textbook, his metaphor was, as emergency physicians, our job is to catch that person as they fall off the cliff, but it's somebody else's job to haul them back up. So we want to make sure that we catch as many as we can and be aware. So stabilizing the patient, then turning on that mind and starting to dissect the case. You decontaminate patients, you try to exclude other life threats and take them off the table as you work through your differential diagnosis. Think of specific antidotes, and if you can't remember, look them up. And then, of course, appropriate disposition. Some patients you have to watch. You can be falsely reassured. We had a patient who was 3 hours into her mental health visit and decided to tell us that she had taken an overdose of diltiazem. 3 hours, which, as you know from charcoal, is a little too late. But her vital signs were not yet bad. So where were you? Was it real? Was it not? And then things started to head south. So people don't tell you the truth. So you always have to kind of think, what don't I know? And then again, talk to your poison control center. So there's going to be a lot of reminder facts in here. This is like a board review session. You go to a class, they try to cram in everything you've learned in 3 years in 3 days. So it's really fast, but it'll be things that you can look at as a reminder. But I want you to use these tools as we go through them to consider these cases. I've got 5 cases. So if you could get a pen and paper, if you want to participate, and jot down some of these facts. And as we go through these different toxidromes and other things, see if you can guess, and you probably will, what the ingestant was, and then I'll tell you the outcome. So first is case 1, the sleeping couple. I'll read these in general, just as you're chatting, as you're charting. So a couple, married couple, I think, had a party. They didn't have a whole lot of money, so they were looking for a cheap high. And lo and behold, they looked out the window of their trailer and they saw something that they could use. So after they did it, in fact, I think I can tell you they made tea out of it. They slept all night, and when they didn't wake up the next morning, their 5-year-old fortunately had the wherewithal to call 911 to save their lives. It's a sad story. So look at their vitals: hypertensive, tachycardic, respiratory rates a little up, a little bit hyperthermic, SATs are down. I put Fahrenheit and Celsius because I always have to do the conversion in my head. We're still stuck on Fahrenheit. So when you examine this patient, and what you're going to find is these cases all look kind of similar, and that's the rub here. So the two patients are unresponsive. One has a bloody tongue. They're both hot to touch. Their skin is dry when you put your hands in their armpits. Their pupils are dilated, and you have a really ambitious medical student who listens to their bowel sounds because he does a complete H&P on everybody and hears that they're absent. You do some labs, you're waiting for them, and they're pretty much normal. And everyone, just so you know, has a normal glucose. So you can eliminate that as the source of their altered mental state. You should always ask for the glucose or check it. I've been fooled so many times. All right, case number 2, a girl with a fever. A young woman came in. I remember the room. It was room 7, right across from where I sit. She had a fever, she had back pain, and then she got confused. And in the age of sepsis, everybody wants a sepsis bundle on this patient. And that's where things were going. I'll just give you that. It's not sepsis because the talk is about something else. Her mom shows up a little bit later and says, the patient is taking Goodies powder. So does anyone know what Goodies powder is? Do you have that in Trinidad or Jamaica? It is I think it's a major food item in the South of the United States. Everybody has some. So if you look up the contents, it'll give it away. But Goodies powder, I'm not from the South. You can hear by my Yankee accent. I'm from the North. So I didn't know what it was until this toxidrome showed itself to me. So, and we'll reveal it later. Hypertensive, tachycardic, tachypnic, febrile, and SATs are okay. When you look at her, here comes Oscar, by the way. He's a 15-year-old guy. He might start barking, and I apologize. He just does what he wants. The patient's agitated. She's covered in vomit and stool. You do some labs, and you're fortunate enough to get them back the same day. And they have the patient has an acute kidney injury. She's acidotic. She's got some transaminitis, and her cardiac enzymes are up as well. Again, glucose is fine. She happens to have an anion cap. All right, case number 3, a man with the sweats. All you know is that he was depressed. There are a couple of empty bottles at the house that the ambulance driver did not put in their pocket, but they're coming. And all they know is the family says, he's going crazy. I don't know what's happening to him. He can't reason with him anymore. The sister shows up later with the pill bottles, and you say, Eureka. But then the attending doctor next to you says, yeah, I knew it all along. So don't be that person. Think about it ahead of time. Be the person who knows. So again, a little bit more hypertensive than the last one, more tachycardic, but not febrile, and oxygen saturation is okay. This person is agitated, confused, sweaty with dilated pupils. He's tremulous, hyperactive movements, and also some clonus and some rigidity sort of mixed in. When you do some labs, the white blood cell count is up, which we know doesn't matter. Surgeons care about the white blood cell count. We're like, yeah, okay, you threw up, your white blood cell count's up. Big whoop. Doesn't tell you anything. Transaminitis again, maybe a clue, maybe a deception. And elevated creatinine, again, glucose is normal. All right, case number 4, a girl in a love triangle. Oh, a teenage girl has an interested neighbor. A love relationship, well, love with quotes for a teenage girl, relationship starts, and then that neighbor starts to shun her. She doesn't want to be included in a 3-person relationship. So she is depressed, she becomes suicidal, and she has a history of tetralogy of Fallot, which gives her access to some medication that other people of her age might not have. So she comes in, she's hypotensive, bradycardic, respiratory rate is kind of normal, not febrile, SATs are a little low. She's a little delirious, she's hallucinating, but she's also drowsy. You see a couple of ectopic beats here and there, and you happen to get a calcium back, it's a little bit low, glucose is normal. Now here's the final case. This is one I saw, I think 2 weeks ago. A woman had a brain tumor resection, and her husband said after that she was never the same. She was depressed. It was a frontal lobe tumor, so she was depressed. She would often disappear. She'd been suicidal, but this day she disappeared. And 5 hours later, when they found her, she was in the woods, comatose, obtunded. When they got here, normal blood pressure, a little bit tachycardic, not breathing very fast, a little bit hypothermic. Believe it or not, in Florida, you can become exposed to the cold, especially in northern Florida. And her SATs are a little low, completely unresponsive, maybe a little twitch here and there, but kind of flaccid, has vomit and stool, diarrheal looking stool, and she too has transaminitis. Okay, I think that was way too much time, but you've got your notes now. Let's go through these cases or through these principles and see where we get at the end. So you start with emergency stabilization. I already alluded to that. You just are an emergency room physician. You do what you need to do to keep them alive, then you think. So one of the metaphors I hear is shoot first, aim later, which is what we often have to do. So, or shoot a bazooka at a fly, whatever it takes, you're all in, you do everything up front. So you're asking them to check the glucose, get an IV, put them on the monitor, get an EKG, all these things simultaneously. And so you, of course, know that A comes before B and C. You stabilize the airway, you intubate early if you need to. And then you start to consider those things that you can reverse. Are they hypoglycemic? No. Is their oxygen level okay? Reasonable. Should you give naloxone? Should you give Narcan if it has the same brand name in the Caribbean? But we are using that like crazy, and you can buy it over the counter now. So people are, I think, giving it to each other for Christmas gifts, for all I know, because opiates are so available now. So you do those things and they work or they don't work. You draw conclusions, but surprisingly, you can give naloxone and somebody recovers and they swear to you that they did cocaine. They have no idea why that worked. And you said, I swear to you that naloxone doesn't work on cocaine. And cocaine does not put you in a coma. Maybe after you burst your aneurysm or you have your stroke, maybe, or your MI, but they will not be convinced. Well, I think a month and a half ago, I was working at one of our outlying ERs, and I got 3 or 4 patients in the same day. And Dr. Who can probably attest to this too. A police officer showed up really irate because he was going to all these calls and found out there was a supplier supplying new stuff. Well, everyone thought they were snorting cocaine. But what happened was the person who was giving them the cocaine maybe ran out, wanted to stretch it a little bit. So he threw a little bit of sugar in there and he threw a little bit of fentanyl in there, or sufentanil or carfentanil, whatever. It looks white, looks the same. They snort it. They think they're going to get high. They go low. So all these patients had a glucose of 300 and they all were asleep and had to be revived with Narcan and were surprised. So, I show a little compassion and I try to tell them a phrase I use all the time. Those people don't care about you at all. They just put your money in their pocket and they move on. Just remember that. Whether they do or not, I feel compelled as a father to say things like that to people. But that's not the time to give them a lecture about their lifestyle, but to show compassion and if they can be educated. But I digress, which I often will do. So these are things that you do because you don't know. The question of flumazenil comes up a lot. Should you use it? And in general, it's not used. It can reverse benzodiazepines, but you might get into status epilepticus. So I put that in parentheses. You can take that off the table. Benzodiazepines are the answer to just about everything. If you got a patient who's agitated, delirious, you basically are just waiting for it to get better and trying to make it easier on you while you're waiting for it to get better. I know that's kind of a cynical thing to say, but those people are suffering and benzodiazepines can often help. And remember, they don't really have a hemodynamic consequence. They don't make you bradycardic or hypotensive, but they do make you breathe a little slower and maybe over sedation. So I get questions about how much can you use, like in a seizing patient. Well, as much as you need until they stop breathing, then you intubate them and keep giving it to them. But the toxic dose for that is so high that you can use it, I could say, almost with impunity. And then don't forget about the effect on temperature. You can use emergency warming and cooling procedures. Okay, now I'm getting in the weeds again. So history. The thing about being an emergency physician is you don't know and you just have to do something. Everybody's staring at you, do something. Well, occasionally you get a little bit of information. So anybody that's around you, even if it's the person emptying the trash in the room, hey, do you know anything about this case? Ask everybody, especially paramedics if they bring them in by ambulance, family members, ask everyone's opinion if this is a perplexing case. Don't ever make it that you're you're not humble enough to ask everyone for help for the benefit of that patient. So ask every question, ask them to bring pill bottles, do everything you can. Sometimes you can't, but things like how much they took, when they took it, it's important in acetaminophen overdoses, as you know. Was it accidental? Was it intentional? What do I have to expect when this person wakes up? Are people doing home remedies? I did my toxicology rotation in New York City with Dr. Goldfrank's group. Fortunately, I went there, I was able to live for a month and work with the fellows. And there were so many ethnic groups there, and they all had their home remedies for stuff. We saw a lot of methanol poisoning because people were brewing their own alcohol. and a different group would have a different one. So you have to stay abreast of your own cultural and know what they are, know what people are taking. It may seem perfectly logical to them, but it'll be something you'll never think of until you hear about it. And then, search old records if you have them available. Always just be a sleuth. So, but when you're in doubt and you don't have that information, just look and touch. Patients come in with no history. You just have to suspect that it's an ingestion. So, and you also, again, which I mentioned before, ER physicians are differential diagnosis generating machines. Every diagnosis that comes in, okay, chest pain, and you've probably been pimped, we say, or asked questions by your attending, okay, give me 5 causes of eye pain, conjunctivitis, glaucoma, iritis, and so on. To graduate, I had to come up with 40 causes of abdominal pain. That was part of our oral boards. Now you come up with 50 when you get experience, but always step back, go through your differential diagnosis. I think this is an ingestion, but maybe it's a stroke, sepsis, environmental exposure, and so on. So don't forget about stepping back and taking a moment. Look at the vital signs, make sure they keep breathing while you're thinking, and again, look at their pupils and so on. And then, is there a toxidrome? This is a term that I'm sure all emergency physicians know, but it was drilled into me. But sometimes when you talk to other specialties, they are not familiar with this. So take your opportunity to educate them what a toxidrome is, because they're the ones asking you for the urine drug screen. What were the labs? Well, I don't have them, but if I didn't do something, the patient would die. I'm leaving that to you to lift them off the cliff and figure it out later, but they're alive. And you can be satisfied with that, because that's what we're supposed to do. But you can recognize these. You should act long before you have the data. And this is a quote from Dr. O'Malley. He was our toxicologist. He trained at the Rocky Mountain Training Center, Toxicology Center, and that was in competition with Dr. Goldfrank's in New York. So he was he always wanted to be the best. But his quote to us, anytime we would ask about a lab test, would be, lab tests are for the weak-minded and the blind. You don't need them in toxicology. You need to use your mind and think and act, and the rest will sort itself out later. That's not entirely true, but he was prone to exaggeration. He was also the kind of guy that would do a spinal tap on somebody to figure out if they had a subarachnoid hemorrhage. Forget the CAT scan. If there's blood, there's blood. I haven't quite adopted that mantra, but So what are toxidromes? If you're studying for your boards, there's this book. It's a little bit juvenile looking, but it's called Toxicology in a Box. If you're a visual learner and you need pictures, these kind of stick out to you. These are great summaries of all different toxidromes and even more rare ones. So I'd encourage you maybe to invest in that if you need a good board review on toxicology. But again, the point is, look things up. You don't know everything. Don't be afraid to ask, and look at every resource, because eventually it coalesces into a diagnosis that makes sense. And toxidromes have overlapping features. All those patients I presented to you before had some vital sign abnormality in common with another one, but yet all distinct toxidromes. So let's go through really quickly. And again, I apologize. I may be repeating myself, but I can provide a PDF for this later if you'd like to have this as a study tool. So opiate toxidromes, they're obtunded. They're obtunded and they have pinpoint pupils. And you can think of the effects. Cholinergic syndrome, they are sludgy. They just weep. So they salivate, lacrimate, urinate, defecate, and they empty their stomach any way they can. Those are the people who are coming in contact with industrial pesticides and things like that. And then near and dear to our heart, and cholinergic syndrome is military people always think about nerve gases and things like that. And you never know when a terrorist decides they're going to do something, you'll need to think of these things and recognize them. Hopefully never. But then the anticholinergic toxidrome, which probably you see more because of medicines like Benadryl, environmental exposure, certain plants can produce this. But you remember, hot as Hades, red as a beet, dry as a bone. That's where we were taught to stick your hands in their armpits. Is it a dry armpit or is it a wet armpit? That can help you in this branching tree that you're building your story from. Sympathomimetics, cocaine, methamphetamines, they're going to be excited. Everything's excited. Fight or flight. And they're usually going to have some delirium. Sedative hypnotics, much like the opiates. They're going to be hypotensive. They may be hypothermic. Variable pupillary changes. They may not be pinpoint. It all depends on what the agent is. Then, of course, don't forget about the people out there who are unfortunately addicted. They're going to have toxidromes that you might confuse with a virus. How many people come in with belly pain? My resident will present that to me. I think they've got the virus that all 10 of the other people I saw, but I maybe ask a question a little differently, and they confess that they ran out of their opiate, a week and a half ago, and everything fits in a nice box. So think of these things as anti-toxidromes or whatever you want. Consider withdrawal as a toxidrome as well. Other medications and over-the-counter medications can mimic this. A lot of them can. Serotonin syndrome. A lot of people take antidepressants. So, and differentiating serotonin from neuroleptic malignant syndrome, you see what I put in the parentheses. Serotonin syndrome is generally spastic, but there can be some muscle rigidity. And neuroleptic malignant syndrome is generally rigid, more pipe, like a lead pipe. Nothing is 100%, and some medications combine the two. So just in general, but guess what? The treatment is supportive care and benzodiazepines. So it's kind of pretty easy when it comes to these things. You just wait for it to wear off. So, and don't forget about malignant hyperthermia. That has some other nuances, but it can look like this as well. Here's just another one of those visual tools that you can use to remember. So diagnostic tests, remember what Dr. O'Malley said, but also remember about the person you're going to give that patient to for inpatient care. They deserve to have some of the data that they need. So order some tests. Well, what's useful? Well, anything you can do right away is useful, really useful. So an EKG, tricyclic antidepressants are still out there. Unfortunately, other medications cause QT prolongation. So getting an EKG can be very quick, easy, and useful. Getting a basic metabolic panel, Tylenol levels, and really, I mentioned the Tylenol levels because there are things, their symptoms don't show up until it's too late. And I'm sorry, I'm going to give you another Dr. O'Malley-ism, but Tylenol overdoses look fine until their liver comes out their butt 3 days later, is what he would say. So they go into toxic liver failure and everything goes wrong, and then you're really playing catch up. So you have to be suspicious. Salicylate overdoses are the same thing. Always be suspicious that there's one more thing that you haven't accounted for. Blood gases can help you recognize the acidosis quickly. And aspirin has different phases, so you might be able to determine what phase you're in. And then there are certain things that you can see on x-rays, and there's a mnemonic for that. Less helpful are urine drug screens. They take a long time, but you should probably know that that person likely did cocaine or meth just by looking at them. Formulas. There are so many formulas, so many mnemonics. I'm just going to quickly remind you of a few. There's the anion gap, the osmolar gap. Those are things that I had to commit to memory to graduate. If you forget, MD Calc is available online. But other mnemonics, mudcat piles, me die, beta chip, those things are all there and get changed every 5 years or so when I think a toxicology fellow needs a research idea or a new paper to write. So you try to keep abreast of it, but remember whatever one helps you remember. There are nomograms, there are graphs that you can use to try to track how toxic it is, should you treat, should you not, and they're useful and not so useful. And then remember, charcoal is a good antidote, but not for everything. You need dialysis for other things. And again, remember that there are some categories of pills that need to make you, we would say, our sphincter tighten. You get a little sweaty and a little nervous yourself when you hear about that, and you know that you have to really jump on this patient and get ready. So here are the formulas. I alluded to them. Here are some of the mnemonics. Remember, mudcat piles for anion gap acidosis, osmol gap for unmeasured alcohols, CHIPE for pills that you can see on an x-ray, and now the nomograms. This is probably one of the most important ones that you should be familiar with, or at least some numbers. And I've got a number that's close enough that you can remember for these things if you get asked questions by another physician. So it has been modified a little bit from its original form in 1975. I think in Europe, the numbers are different. That's why you see those two different lines. Same thing goes with HCG, quantitative HCG for some reason. What we consider a threshold zone, other people in different parts of the world consider differently. But nevertheless, this is just a general tool. It's only a guideline. It depends entirely on if you know when the person took the overdose and that they did it in one sitting. It can be useful in absolute numbers if somebody has been doing it over a period of time, but it's a tool. And if you suspect that the antidote has few side effects, mucomist or N-acetylcysteine whatever brand name it has, really has not much detriment except for the way it smells, like rotten egg. So convincing people to drink it is probably the only side effect. But know this, pull it up. There are, again, apps on your phone that you can use to quickly diagnose this. And the number I want you to remember is 140. And actually it's 150 and 140, but I think this works. A single toxic ingestion of Tylenol, 140 milligrams per kilogram, should be considered a single toxic ingestion. And even if they have no side effects, aggressively treat that person before they need a liver transplant. Also, at 4 hours from ingestion, if your minimum number is 140 micrograms per milliliter, again, 140. If you're trying to remember the initial loading dose of N-acetylcysteine, 140 milligrams per kilogram. So that's a good tool that you can use. There was a nomogram for aspirin. They tried to determine what's toxic and what's not. Unfortunately, it really worked only with kids with a single ingestion. It wasn't very reliable, and it's kind of been abandoned. So in general, if you want to remember aspirin, just remember, check a trend. Check 1 aspirin level, check 2, check 3. And if the graph is going up, start thinking about calling the nephrologist or transferring them so they can get dialysis. If it's going down, then just do another one and watch it a little longer. But the numbers you might want to remember is 150, 300, and 500 has more consequence. All right. Again, this is for your study later if you want to. Remember, aspirin starts with a respiratory alkalosis, then your pH is normal as the metabolic acidosis counteracts that, and then the salicylic acid takes over and you become acidotic. Be very careful of these ingestions. I know a case from my residency where this was overlooked and a patient died on the psychiatric ward because they thought he had the flu. He got a fever, and so it went. It's unfortunate, but it still happens. So I jumped ahead a little too quickly. Look at your notes. I know that was a very quick thing, but let's look at these cases now. So case number 1 was the couple who had to be woken up by their kid. Well, it just so happens that they had a tree outside their trailer called an angel trumpet. There are quite a lot of those around here. There are other plants that produce it, belladonna-like medication or like substances that will give you an anticholinergic toxidrome. So they were out, they were tachycardic, they were febrile. So with supportive care, fortunately, they got better. And fortunately, their children were reassigned for a time to an environment where they didn't have to witness that. The second case was the young lady with a fever and back pain who had been taking Goodies powder. Well, Goodies powder is what people take when they have back pain, headache. It's full of aspirin. I assume the amount is regulated, but people take these packets in mass. They buy boxes, and it comes in a little envelope. They tear it open, they eat it, they move on. So they don't appreciate the potential for overdose. And this girl had been doing it because she had some mechanical back pain for a few weeks and was doing it without any discretion whatsoever. So what I thought at first was pyelonephritis turned out to be a salicylate overdose because her mother came in and gave me that one vital clue. Thank God she came, because I would not have figured it out probably. The next was a guy who had depression. You probably realized he could have serotonin or neuroleptic malignant syndrome. In his case, it was serotonin. But if I recall, he did have also, it was a mixed medication that he took. But supportive medications, we found out that it was an SSRI. The next, the love triangle. This girl had tetralogy of Fallot, so she was on a medication to keep her heart rate from going too fast. So she was on diltiazem. And she had access to that medication. She may have known that it was fatal, so she took a huge amount of it. She came in talking to me, then she started hallucinating. And as I was calling the Children's Hospital Center, she was only 14 years old, she arrested. So now she had VTAC. We were defibrillating her. Then she woke up and started talking to us again. Believe it or not, after that event, she left, not intubated, went to the Children's Hospital, deteriorated some more, and then was saved by ECMO. If you have ECMO on the island, think about that as a last ditch for these cases. And fortunately, her life was saved, but I know of, unfortunately, too many beta blocker and calcium channel blocker overdoses who don't make it because it is just miserable to treat. You try everything. And then finally, the last one was the girl who had a brain tumor and changed her personality. She overdosed in the woods. What she did was she had a mixed overdose because she took a medication we call Fioricet here. It's a combination of butalbital, acetaminophen, and caffeine. So each one has a specific toxidrome. Acetaminophen is a little more silent, but that's where the transaminitis came from. The caffeine was some of the tachycardia and the relatively normal vital signs. And the butalbital is a depressant. Caffeines in excess can cause seizures. Butalbital is a barbiturate, so it suppresses the seizures. So they can complement each other in a good or a bad way. She's still being treated, so I can't tell you the outcome of that particular case. So hopefully that was empowering to you, and reinforces what you already know. And there's way too much to cover in one talk, but there are general principles that you can take away and just approach these patients the same way every time. So you have a patient, they come in, you don't know what they took. Everybody's telling you something different. You've got to do something because they're sick and getting sicker. So where do you start? Well, remember, decontaminate, support, give them an antidote if it's available, and anticipate what's coming next. So any decontamination, you can, and I'll talk, and just to remind you a few of the things out there, each one has specific, but I'll talk about charcoal specifically. And even before that, let me talk about Ipecac. Is Ipecac still used? You find people who get a hold of it and they come to the ER having given it to their child? Not so much, right? I imagine people could probably find it on Amazon, but the idea of inducing vomiting makes sense, but not if it's caustic and all the acid and the aspiration that comes with it. So hopefully nobody uses that anymore. Then there was activated charcoal, which when I started in emergency medicine in the 80s, believe it or not, as an orderly, a nursing assistant in the ER. So we were putting charcoal down NG tubes. We were doing it 4 or 5 hours later. That has all changed. 1 hour is generally when it's accepted, unless it's a particularly catastrophic overdose, then give it a try. You don't want to be sucking that out of someone's lungs, though. So activated charcoal. The other thing that used to be, I'm a big guy, so guess what my job was? I got to lay on top of the patient while they put an EWAL tube in them. And maybe some of the more seasoned physicians remember those. When you look at all the old television programs, they talk about pumping the stomach. Well, this was a contraption with a huge tube that you stuck down the esophagus. And in a patient that may not be sedated, maybe only sedated by their overdose, and you would flush water in and out and lavage the stomach. Aspiration risk, esophageal perforation. I think of all the things now as a physician, I know I feel a little bit bad that I participated in that, but college student, what did I know? So fortunately that's gone away. But there are other things, whole bowel irrigation, hemodialysis. There are new types of dialysis too that are a little more gentle on the heart, like continuous dialysis. But when you're decontaminating, you're either trying to eliminate it or absorb it, take it out of action. I talked about those things. When you're increasing elimination, you can do that by changing the urine pH to eliminate that way by ion trapping, or use hemodialysis, or multi-dose activated charcoal, one after another, because some medications, unfortunately, are secreted back into the GI canal or GI tract after they've been absorbed, and they keep having their effect by being recycled on the way down. So again, an hour is typically the limit of when it can be useful, because that's about the time things dwell in the stomach. But again, you can do it multiple doses, and sometimes you're just throwing the kitchen sink, so they say. Whole bowel irrigation. If you want to be liked by your emergency room nurses, don't do this in the emergency department. Just like lactulose, just like K-Xylate for hyperkalemia, I've had so many nurses beg me to not start it until they're on their way up to the ICU. Now, I hope the ICU nurses don't know my name, but that's been somewhat of my practice. But most of these elimination pathways like that take a long time and repetition, so it won't have an immediate effect in the ER. But there is some policies that now state that it probably doesn't have as much utility as we thought. Remember, there are things that don't get absorbed by charcoal, heavy metals, acids, and so on. Alcohols, you need to have special methods like hemodialysis. And sometimes to get rid of toxic alcohol, you have to give alcohol. If you don't have an alcohol drip, give them a beer, give them some whiskey, unconventional treatments. It's always kind of amusing that your patient is drunk because they were drunk, on something that they shouldn't have been drunk on. So there are other specific antidotes, digibind, and sometimes you have to use bicarb for tricyclics and so on. So remember those things. And then again, remember there are lists of antidotes. There are 3 pages of these, and there are many more. This is just a quick site reference for you. You can take a look at those. I need to catch my breath for a moment anyway. Chelating agents, so on. And things you might not remember, protamine. For some reason, I have a mental block to remember protamine. And you have patients who are being treated for TB and they're on isoniazid, but they forget to take their B6 and they have status epilepticus. Well, you might have to get all the B6 in the country. We have to call around. Most pharmacies don't have enough. And then other novel things that are coming out that they do not do prospective research on, because you can never, you just have to do case studies and hope these works. Things like intralipid and high dose insulin and so on. Remember these particular things. If you hear of a kid that takes a sulfonylurea, be very afraid. Camphor, things that are in closets, mothballs. A lot of commercial products, they've taken away a lot of these things from availability to kids, but they're still out there. Oil of wintergreen, even things like Visine. Kids will drink anything if they're excited. Clonidine and so on. So all that being said, if you are in a hurry, you don't have a lot of time, you're trying to piece things together, there just so happens to be an article that you can reference. One of the things we have to do is some publications. So this is something I did early when the residency started. So I like toxicology, so I wrote this article, and it's on stat pearls. If you type stat pearls and Euwema, I guarantee there's no other Euwema out there. It's a very weird and weird Dutch name. Even in the Netherlands, it's a weird Dutch name. So type in those two words, stat pearls and Euwema, and you'll get a quick reference. There's the address at the bottom. But please feel free. And if you find mistakes, please feel free to tell me. I read through it recently and I didn't find any, but things change. So I was talking about home remedies that are out there. There are some things like new things on the street. I don't know in Trinidad, but I assume that the drug problem you have is the same as the United States, or maybe a month behind, and you're a month ahead of us on something else. It all depends on what the smugglers do. But try to talk to the police officers, talk to people in the jails and law enforcement. That information is highly valuable and will save somebody's life. Right now, we're having problems, as everybody is, with every iteration of fentanyl that seems to be freely available on the internet. We did for a little while have something called Spice, which was a synthetic marijuana. It's not really marijuana, but it was intended for research purposes, and it got out there. I think that Demi Moore, a famous actress, probably tried some Spice and then got delirious, ended up in a hospital. So don't be one of those people. There are new designer drugs, like I already mentioned, this combination of sugar, fentanyl, and cocaine. Who would have thought of that until it happened? And I talked to a police officer and they had figured it out. We're seeing a lot of heroin again, IV drug abuse. And then there's always the old faithfuls. Marijuana is getting more and more legal in the United States. As you know, the liberality has no end in the United States, and things are progressive, and things that I grew up with that were verboten are now freely available. Even before they're legal, they're freely available. So marijuana is one of them. And we're seeing people who are getting this industrial grade marijuana and are vomiting, and having 80-year-old ladies who come in, they were trying just a little piece, and then they decided to have 3 because it tasted so good. True story. 2 old ladies came in after having coffee down the way, and they started acting funny. And one of them was the mother of a paramedic I knew. So yeah, you never know where this will show up and in who. LSD is still around. But there are some resurgences of things like bath salts, and then over-the-counter medications are readily available. Robotripping on chlorocidin, you can get a serotonin-like syndrome. So think of those things too. They're always in the background. So just to summarize and reinforce what I've already said, you're an ER physician. You go in a room, there's chaos, and everybody looks at you because you're the person who can make order out of chaos. That's your whole purpose for being. Maybe that's whittling it down to a little too simple, but you walk in and you're the person who's supposed to get rid of all that other stuff, and then the sun shines and you've solved it. Not so easy, but if you have a process, if you have a method that you approach all these cases from, you're more likely to catch it. So stabilize first. That's what we always do. We save their life, and then we figure out why their life was threatened. Airway, 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 airway. Don't get so caught up in something else you're doing, like an IV or whatever, to forget that the patient stopped breathing, or assign somebody to watch. Ask everybody you can, even the janitor, if they know something about what happened to this patient. Touch the patient. Look at the patient. I'm glad COVID is settling down. We can get close to people again. It might be a toxidrome. It might be 2. It might be 3, all mixed together. You don't know until you look. and the lab takes too long, your mind will save that patient, not the lab test that you get 2 hours later. And always be suspicious in any patient of an occult ingestion, anybody who has altered mental status. But likewise, always think of metabolic causes of altered mental status in patients you are sure are an overdose, so you don't get fooled. So I'm basically telling you to be perfect all the time, to think of everything, and always be able to fix everything. It's easy, right? Maybe by the time I see my very last patient, I'll probably be 85. I love this so much, I'll keep doing it. I'll know everything at that point, and that's the day I have to retire. I think it's unlikely. I think I'll die first, but it's a great specialty, lots to know. So I have a lot of sayings that I pass along to my residents you probably caught on. So I was asked to just bring up a couple of pearls of wisdom, or life hacks. I guess that's a millennial term, life hacks. So I threw that in. I'm not a wise sage. I'm just a guy that has gray hair, because you get older, you see things, you do things. But if you don't shy away from it, and I haven't found an emergency physician who is shy. Maybe they're soft-spoken. Dr. Who, if he's still on there, very soft-spoken guy, but a powerhouse intellectually. That can be your shtick, or you can be the person who goes in the room and says, "Shut up, listen to me," whatever it is. But take away from it that this is your job. Be bold and don't be afraid, and take your place in life. So in the United States, it's a business. Medicine is a business. We happen to work for a for-profit hospital. It does quite a bit of benevolent charity care too. So that for-profit thing is, I think, a little bit unfair. But nevertheless, we get asked about, how quickly did you see that patient? How quickly did you order that test? Did you get them out in 120 minutes? So we're constantly asked and monitored to how we do things. Eventually, you have to step back, because there are so many external inputs and so many people who know how to do your job better than you. You just have to smile, nod, and then ignore everything they said to you. Be nice, keep their respect, but you got to know when to ignore it, because they really don't know what they're talking about and they don't get it. You don't have to be rude to them, but then turn around and do the right thing anyway. So don't let those oppressive things that are in our specialty, that all those extra things, don't let them take away from the joy of this job. And you're doing the right thing, and be confident you did. And it works itself out. And besides, the thing they complained about 2 weeks later, they'll have forgotten about, because there's something new to complain about. So the other thing is, we are ED docs. We just fill in the blanks for that word, out. I don't want to swear on a presentation on YouTube, but we just figure it out. So you're going to work in austere conditions. The lab isn't going to work. The nurses didn't show up. You have to go out and start your own IV, whatever your particular problem is. And in a case that you can't figure out, no one else can, you still have to do something. You have to keep them breathing. You have to try something. Don't be afraid to be bold, because you are the last person that a lot of people will see. You're the last hope for that patient. So be bold and use your mind and be confident. We are the ones who are supposed to be figuring stuff out. So have pride in that. And then this kind of goes along with the pride part. If I have a neurosurgeon I'm talking to, I call him by his first name. Easier for me to do, because I do some hospital administration and I sit in meetings. I have some pseudo authority, and I'm old. But I learned, and I tell my residents when they graduate, as soon as you're an attending physician or a consultant, I think is how you refer to that in Trinidad, at least. When you're a consultant, that neurosurgeon is a consultant too. So is that cardiologist. So is that nephrologist. You're a specialist in emergency medicine. You figure stuff out when other people can't. So call them by their first name. Treat them like a peer, because that's what they are. And there's somebody to give you their opinion, but that's your patient. So you deserve a place at the table, and don't forget it. And this specialty is new in some places. It's been around here for about 40 years. We had to fight our way to legitimacy from the Department of Surgery. And I hate to sound so militaristic, but this is a great specialty. We deserve respect. And you don't have to tell people you must respect me, but don't let them disrespect you either. In a polite way, smile, nod, and ignore. So anyway, I guess that's all I can say. I feel like, I don't know, motivational speaker or something, but this is the reason why I'm happy and I love my life right there. My wife is in the middle, and she is not from Trinidad. Although when we go there, I swear she thinks she is. And my kids too. When I go to Trinidad, I tend to stand out. But my kids love it, and we go there as often as we can. So that's what I have. Thank you for the time, and I'm open to any questions. I'm on island time. I've got plenty of time.
Thank you very much, Mike. Do we say Euwema? Do we have any?
I'm sorry, I didn't put that in there. In the jungle, the quiet jungle, the lion sleeps tonight. Look up that song. That's our family theme song. And you just learned the Euwema way. So, and thank you for calling me Mike.
No problem. So just want to introduce, just so you'll know some names. Our university lecturer, the person who's our boss is Dr. Jean Johnson, always get this wrong, Jean Johnson Williams or Jean Williams Johnson. So she's from Jamaica and she might be on here. I know she was on initially. So Jean, if you're here, just to wave and say hi to Mike, so at least you'll have her face, if that's possible. And the ones to know about, we have Simone French from Jamaica. So she's the coordinator of the program in Jamaica with the university also. We also have Dr. Okay, Simone is waving. So you can see her face, Mike. Oh, she waved, yeah, so she's gone. And then we have Dr. Krista Wells, who is from Bahamas. So she's a point person there in Bahamas. And then we have Dr. Reginald King. I think he was on earlier also. So he's from Barbados. So we have a few key persons in those other countries. And as you know, Arvin Ramnarayan in Trinidad is coordinator of the program here. And I wanted to ask anybody who's from the Caribbean islands. Well, I have a few questions here, Mike, but I wanted to ask, I know we use Talkspace and we use our Poison Center, which is open 8 to 4, but I want to ask Barbados, Bahamas, any person from there, and also Jamaica, what do you all use in your specific country for toxicology phone in terms of advice per se? And do you all have it 8 to 4 or do you have it 24 hours as most of us don't? If anybody, any resident or any lecturer would like to give me some feedback, that'd be great. Anybody from the other Caribbean islands? I know nobody's keen to say, just you don't have to put a video on, just audio is fine.
Hi, Joanne. I had put it in the chat. This is Dr. Wells. We use the 1-800 number that Mike would have listed earlier in his presentation.
Sure.
The US number 222-2222. That's what we use in Bahamas.
Right, and you'll have to pay, is it toll free or?
Once you call direct, they will usually put you on to the nearest center. And it's free for us.
Okay. Okay. Mike, we have to work on that, man. We have to get a treat for the other Caribbean islands, man.
Yeah. There may be a grant somewhere there, huh?
Yeah. Thanks for that, Dr. Wells. That's a point. She's a point for Bahamas. Anybody from Jamaica? Just tell me what you all use in Jamaica.
Night John, Dina, Kernon.
Dina, hi.
Hi. So we have the Caribbean Poison Information Network that's run out of the University of Technology. It used to be 24 hours. I don't know where they are in the process of getting it back to that stage, but at this point, I think it's still a 9 to 5. It's been a 9 to 5 for a few years now. So that's our local pharmacy program that runs that in conjunction, I believe, with Dr. Williams Johnson is a part of that team when last I checked as well. So they have a website as well as a number that's available in the daytime. They have a lot of prevention literature available that we can use to like help educate parents about medication safety and the safety of, household items, that kind of thing. So that's available locally as to how much use we make of it, or just, like local pharmacy. You call the person who's on call for your hospital, or you call the nearest emergency physician that's available to you. Over.
Sure. So it you say it's 9 to 5. Is it only during the week or is it on weekends also?
I think it's 9 to 5 during the week. I don't think they have the after hours coverage at this point in time. I know it's a work in progress. They were trying to get it back, but I can't say that they have that up and running at this time.
And it's only for Jamaica because it's called Caribbean, but is it available for the Caribbean also or just for Jamaica?
Because UTech takes Caribbean students,
right,
then, you know, the students who've gone back to islands, who would have been at UTech would be aware of it. So, you know, if you know the number, you pick it up, you call, they'll answer. And I know that they do give advice to any island that calls them.
Sure.
But I can't say for sure how many of the islands are utilizing the facility.
Sure, I understand. Cool. And just anybody from Barbados, just to give us some feedback at all. Barbados, Mike, is one of the smaller of the Caribbean islands, but still very significant in terms of academia. Anybody from Barbados enlighten me at all?
While you're waiting for that, it's interesting that how they're staffed. Here, it's a nurse or a technician who uses a database and they basically just answer questions and go through. If it gets beyond what the computer will generate for them, and they have experience as well, you can ask for a toxicologist consult. And in the United States, at least, we have emergency medicine fellowships specific to things like ultrasound, toxicology, critical care. But pharmacists, like you were saying there too, are also getting into this. So you might get someone on the phone. We have the luxury of a consultant for those really rare cases to help you think through them.
Sure, no problem. So I had a few questions, Mike, that came up via our YouTube and also via Zoom. I'm just going to start with that, and then I'll just open the floor to anybody else who has any questions that they put in the chat or they want to vocalize. And going through here, we had the first question was lipid emulsion therapy. Do you use a lot of that at all in your hospital in terms of any of your?
It's brought up, and generally, if we have a calcium channel blocker overdose or a beta blocker overdose, we think of it right away. We call it intralipid. That's the product that we use. I have used it. That one case that went to ECMO, that young girl, I was giving her high dose insulin, glucose, and intralipid, everything I could. I wouldn't say it's first line, but when people start to deteriorate, that's when we start to, you're putting them on a presser and doing everything else. Then you start really throwing, we call that a kitchen sink kind of move. It's mostly anecdotes and case reports. But.
Right. It used to be so like therapy that was in the future, but now I think it's coming on very frequent and it's very much the standard. Do you think it's effective, or do you think it's just so large ditch that it's kind of hard to decide if it's effective or not?
Yeah, I think on balance, when it comes to harm versus benefit, so much benefit versus very little harm that it's worth a try. And it's usually a matter of availability and expense, I guess, and how much do you use. Most poison control centers will give you a protocol that they have. They'll fax it to you, give it to you over the phone. But I mean, the principle is you competitively bind or you scoop up those floating molecules of the medication. So it works for a lot more things. I would say if you have a deteriorating patient, I would try it on everybody. I'm not a toxicologist, but there's not a lot of harm with giving a dose of intralipid that I can think of. So
no problem. And the other question I had was that we had come up was, well, you mentioned that it was 46% children. What was the common toxic ingestion they had with children? Was it still also analgesia, or was it
usually household products, if I recall.
Right.
I had a slide on a previous iteration of this talk, and that was generally what topped the list were household products. I'm sorry, I don't know if it's, it's the second highest when you're looking at all exposure, so it would stand to reason. They don't have as much availability to those other medications unless they get into grandma's clonidine or something like that.
Sure. And the other question we had, so like a cheeky question, did you during the past 2 years see a lot of hand sanitizer ingestion?
Yeah. Yeah, I remember a case of one. It was a prisoner who got a hold of some. And if I remember, weren't they making hand sanitizer by the gallon or by the ton in Mexico? And they did a particular formula that was especially toxic, both through skin, but also if ingested. I seem to remember a news story about that. But I think, I don't know, I hate to say this, with the cheapness and the availability of opiates, I don't think people have to resort to that as much. If it's a high school student trying to conceal it from their parents, they might go for mouthwash instead or something like that. Right. So I don't see it too often.
And you mentioned about spice too, synthetic marijuana. I think people were curious about that. What's different about it? Because I mean, is it the same formulation? I mean, what's the major side effect? Is it more potent? What's the major effect of it?
It's both more potent and I think chemically dissimilar to marijuana. I think they used it in rats in research and somebody got a hold of it and they promoted it as a synthetic marijuana. And because when you bring things out and you put it in a gas station somewhere, it evades the FDA for a little while. So it was available and they were saying as legal marijuana. But now I guess one of the good things about marijuana being so prolific or so ubiquitous, whatever you want to say, probably we don't see that as much anymore because they can get the real stuff. But it would cause sometimes permanent delusions, brain damage, psychiatric disorders, seizures. So the word caught on pretty quickly about that. I haven't seen that in several years.
Right. And the last one I had here was detergent pods. Do you see a lot of that coming in? Because that has become very colorful now. So I think the pods have been small and easily ingested by both children and young adults.
Like laundry detergent pods?
Yeah.
Yeah, our hospital, we get a lot of children and we have a lot in there, but there is a children's hospital in our city. So we don't see as much. Our residents just are starting their rotations now. It's called Wolfson's Hospital. So I'll have to ask them, but I have not yet seen one. I hear about it in the news, but personally I have not.
Right, sure. Okay, cool. I think that's some of the questions we had. I mean, I'll open the floor now to if Arvin or Olean have any questions from the other side, any more of them. And also, as we wait for Olean or Arvin to mention, just want to say that I know that your one of the intentions you have is to try to be the ambassador for Trinidad. And I'm not sure, we wanted to ask the other Caribbean islands who they had for their ASAP liaison. I think on the site, there was one for Jamaica. There wasn't one for Barbados. I think I see one for Bahamas. But I know that you're trying to also organize with that. Any feedback with that in terms of how far it's reached?
Sure. Let me share this with you. ASAP has that big A on there, the American College of Emergency Physicians. Fortunately, my colleagues and the people I've met don't feel like we have to show the world how to practice emergency medicine. I think we've realized and we've come to realize the humility of the fact that there are so many smart people in the world. We want to learn from them and learning how to operate in an austere environment, coming up with a remedy that we would never think of, something that's local, so the American College of Emergency Medicine helped with a couple of other organizations to form the International Federation of Emergency Medicine. So there's much more of an outreach for, unlike countries like yours that are highly developed and have EMS and an organized healthcare system, places like Central Africa where maybe access to emergency care isn't there, coming up with novel ways to implement an emergency care system, an EMS system, where to start. They have a lot of tools like that. But stepping back, there are people who had interest in emergency medicine around the world. For me, it's mostly curiosity. I want to see how other people do it because I'm tired of listening to people here, And so there is this website, asap.org. And if you just type in Ambassador ASAP, this interactive map comes up. And I think you should be able to go on the map and it'll let you zoom in by country to see where emergency medicine is an established specialty and where there's like here, if you click on this, it should highlight to you which countries have it as a formal specialty. Conspicuously, the United States has no data I can't figure out that part because it is an organized specialty there, but you know, Canada and parts of South America, and you can of course then zoom into Trinidad and the Caribbean islands. Caribbean, I always forget how to pronounce it properly, but so if you use this map, you can look and see, and if you don't, you can probably contact either me if I do get the ambassador spot, or ASAP directly to say, is there anybody who was, is there interest? And it's very much is meant to be a shared relationship. So anyway, they have ambassadors, liaisons, deputy ambassadors, they all have a different role. So I think I over answered that question, but
sure.
I know Trinidad. So.
And you mentioned about some research program.
Yeah.
Yeah. Mm-hmm.
See if I can find it. So coincidentally, our research director, who we got just in the last year, he's a new consultant or attending physician for us. His name is Martin Wegman. He was appointed the research fellow for the American College. So he coordinates and kind of directs it. They've had this program in the American College for a long time. It's quite pricey, as we talked about yesterday, but it's a year-long course with some in-person sessions that happen that go for a week at a time, and it can be almost, I don't know, anywhere between $1,500 to $3,000, and then you consider lodging and things like that. The American College just met a few weeks ago, and they're talking about trying to make this international. And he mentioned to me that they were looking at maybe India and South America. And then he said, well, the only disadvantage is many people speak Spanish in South America, so it would be difficult to implement. And I said, have you heard of Trinidad, Jamaica, you know, the Bahamas? There's English everywhere, kind of a natural ground. So this is a very, very much just a kernel of an idea. But he was excited. The idea is still in its infancy, but maybe to take this on site to different places, make it more virtual. But it's basically to have some tips from world leaders in medical research and emergency medicine research in particular be at your disposal to help you publish, you know, so our community can grow, because there's great research happening all over the world. We just have to hear about it. And until we talk to each other, we never will, or we'll duplicate our efforts, you know. So this is something exciting that may be coming probably a few years out, but the focus is on the Caribbean now, or Caribbean.
Thank you very much, Mike. This has been lovely. I want to say thank you very much for your excellent lecture. It was difficult though, because toxicology is so wide to bring it in and just have some framework and structure. And it's been lovely getting to know you over the past few weeks, trying to have a connection. And of course, I know from here, we're going to try to have you guys have a few guest lectures with our program. And of course, I'll invite the other Caribbean islands if they wish to either have a connection for you as liaison, or going further. I think I have to mute someone. Hold on.
And I think, you know, working with the University of the West Indies is such an ideal opportunity, because you do span different countries, but yet are one institution. So it makes it easier. And yeah, we're eager to see where that goes.
All right. Any questions, comments from anybody else? Jamaica, Bahamas, Barbados, anybody else in Trinidad? Any questions you want to ask Mike, guys? The floor is now totally open.
Hi, Dr. Paul.
Hello.
So this is Oliane here. So in the chat, we have one comment and one question. You already asked all the questions that we had on YouTube already. So the comment is from Dr. Simone French. She stated very helpfully that Tricia Smith is the ASEP ambassador for Jamaica.
Great.
And there is a question from Judine Frank. She says, good evening. Could you please repeat what is the timeline or the deadline to give activated charcoal and for a gastric lavage to be done?
Thanks so much.
Sure. And you can answer that too, Dr. Paul, if you want. In general, we don't do gastric lavage anymore, at least with a device. But whole bowel irrigation in certain situations are done for high risk ingestions, large volume ingestions, like somebody took 2 bottles of delayed release acetaminophen You just have to pull all the stops out and get that out. Non-charcoal, things that won't be absorbed by charcoal. But in general, in the United States, at least 1 hour is the time beyond which we don't give charcoal, unless it's a special situation. But many of us push that envelope because we grew up before that 1 hour recommendation was there. But 1 hour is the official answer.
Okay. All right. Anything else, guys? Last few minutes before we close, we want to make sure we're tight. And we know it's 8. We told Mike, we're going for 1 hour, 1 hour and a half maximum. It's nighttime. Anything else before we end, guys?
Can you all hear me?
Yeah. Mm-hmm.
All right. So I just wanted to thank Dr. Euwema for the wonderful talk. There are some really good points that we took away from that. Just to let him know that I do recall before the days of easy internet access on your phone, we actually did have to utilize the U.S. Poison Control Center phone numbers on a few occasions. Back, that would have been a little bit before 2010, 2009, 2008, right? And they were actually quite helpful. I cannot recall what was the indication at the time, but we have actually used it in Trinidad before.
But you had a few that don't have it. Isn't it's 1-800 numbers now aren't free?
No, they're not. But at the point in time, we needed access to it.
Mm.
And I talked to one representative. I just called her today, so the opinion may be different. She was a little bit ambiguous on the answer, but at least someone will pick up the phone. So, and think of that 222-1222. That's the number with a 1-800 in front of it.
Right.
And again, the number may not be free, but in situations where you do need a resource, especially back in the day, it was quite useful.
Sure.
I would love to, I am very happy to see that emergency physicians feel the same pressures and have to fight for their validation anywhere in the world, just as we do here. Right? So it's always good to know that all of us are doing the same fight, right? You can rest assured that the same thing happens in the Caribbean, right? Where we basically have to be telling all our colleagues that we are peers, right? And it's not a matter of one of us telling the other one what to do. So it's good to see it's the same worldwide. Yep. So thanks again for that.
Absolutely. And I don't mean to sound like a martyr. I hope I didn't, but the people just don't understand you until they understand you. So we need to be apologists for our specialty sometimes.
You sound like an emergency physician.
I'm telling you, it's a fraternity, an exclusive one, but I'm glad to see it grow.
Jean Williams-Johnson, do you wish to mention anything at all? Any comments by you, Jean? As I said, Jean is our boss of the entire program in the Caribbean. So, and Jean is a university lecturer from Jamaica. Hey, Jean, still there? Do not show yourself as we sing the song. Euwema, Euwema, Euwema. I have to get out my. That's just so excellent.
If I get to do another lecture, I'll try to start it off with that.
No problem. All right, come on, get Jean. So anyway, I'm sure Jean says hi, and in the chat we have lots of thank you very much. So it's 8:30. So guys, thank you for your contributions. And we started off by 7. We knew it's gonna go for an hour and a half. And it was thanking you for having your patience to listen at this late time. And thanks to Mike and his team from your, is it Orange, what's it called again? Orange, your hospital?
Orange Park Hospital.
All right, Orange Park Hospital. Thank you for contribution. And I know we're gonna have a continuing relationship where we'll have you being in with our students and also having maybe our students come by you guys and also you guys come to us. And of course, going with the Embers program, I want to get some more information about that and see if we can have it where it's subsidized or at least free for some of our colleagues in the Caribbean. All right, so Salim, you want to mention anything before we close?
No, that's to thank everyone for coming out. Same thing as Dr. Paul was saying, hope it was beneficial. Got some private messages that say it was an awesome session. So let's let you share that with you and give us some feedback, Dr. Mike. And Dr. Ed, thanks for joining us as well. We appreciate that interaction and your that cross-island camaraderie. Yeah. So thanks once again, and everyone. Thanks for the session. The next session, Grand Rounds, Jamaica will be hosting, and it will be in December, God willing. All right. So
November,
once again,
December.
I think it's December. I think it's December. Yeah.
All right.
Yeah.
Last thing, guys, just for the trainees out there, I think tomorrow, school may be closed. If you can check your any messages on WhatsApp, etc. I think because of the orange
Level alert. Yeah.
might be. So just
Schools are closed.
What's that?
Yeah.
Sorry.
They are closed. The ministry sent out a memo.
Right, sure.
Okay.
So just be careful. Don't send the kids out tomorrow. Kids at home. The school will be closed tomorrow as we go through one of the many thunderstorms. All right.
Okay.
Thanks, Mike. Thanks, guys. Have a great one.
Thanks.
Bye-bye. Ciao, ciao.
Take care. Right.
Thanks so much.
Bye, everyone.
Thank you.
Bye, everyone.
Bye, guys.
Right.
Bye-bye.
Bye, everyone.
See you. Bye-bye. Ciao, ciao.